Intestinal ischemia refers to the intestines receiving inadequate blood flow. When this blood supply is reduced, intestinal injury can occur rapidly and may progress to bowel necrosis. Patients classically present with severe abdominal pain that is out of proportion to the physical exam. Although mesenteric ischemia is rare, affecting only about 2 to 3 people per 100,000, it mainly affects older adults and carries a very high mortality in acute cases, reaching 50 to 80% largely due to late recognition. The intestinal blood supply arises from 3 major branches of the abdominal aorta: the celiac artery, the superior mesenteric artery, and the inferior mesenteric artery. The celiac artery supplies the foregut, so the distal esophagus, stomach, proximal duodenum, liver, spleen, and pancreas. The superior mesenteric artery, the most critical vessel in mesenteric ischemia, supplies the midgut, so the distal duodenum, jejunum, ileum, cecum, ascending colon, and proximal 2/3 of the transverse colon. The inferior mesenteric artery supplies the hindgut, so the distal 1/3 of the transverse colon, the descending colon, the sigmoid colon, and the proximal rectum. These arteries are interconnected through extensive collateral networks between the major mesenteric trunks and arcades, normally protecting the bowel during gradual reductions in blood flow. Certain border zones, also called the watershed areas, are particularly vulnerable to hypoperfusion. The most important are the splenic flexure, also called the Griffiths point, and the rectosigmoid junction, called the Sudeck's point, which are the most common locations for colonic ischemia. Let's walk through how acute mesenteric ischemia develops at the vascular level. The most common cause is arterial embolism, accounting for about 50% of AMI cases. In this situation, a thrombus forms elsewhere, most commonly in the heart, and then travels through the arterial circulation until it becomes lodged in a mesenteric vessel. Typical cardiac sources include atrial fibrillation, recent myocardial infarction, valvular heart disease, infective endocarditis, or recent cardiac or vascular catheterization. In more than 75% of cases, the embolus lodges in the superior mesenteric artery, usually in the mid to distal segment, just beyond the origin of the middle colic artery. Importantly, the proximal jejunum is often spared because branches before the site of obstruction continue supplying that segment. However, the remainder of the small intestine and often the proximal colon lose their blood supply and become ischemic. Now, let's continue with arterial thrombosis, the second major cause of acute mesenteric ischemia. Arterial thrombosis accounts for about 25 to 30% of cases and typically occurs in patients with pre-existing atherosclerotic disease. Unlike embolism, this is not a clot traveling from the heart. Instead, the artery has been narrowing slowly over time due to atherosclerosis. The acute event happens when a thrombus forms on top of a chronically diseased vessel. This is called an acute on chronic occlusion. Where does this usually occur? Most commonly at the origin of the superior mesenteric artery, where atherosclerotic plaque tends to develop. The celiac artery origin may also be involved. Because the blockage is so proximal, blood flow to nearly all downstream branches is cut off. As a result, the ischemia usually involves almost the entire small intestine and can also extend into the right colon and proximal transverse colon. Now let's discuss non-occlusive mesenteric ischemia, which accounts for about 20% of acute mesenteric ischemia cases. Here, there is no arterial blockage, but blood flow is reduced due to systemic hyperperfusion such as shock. During shock, blood is diverted away from the splanchnic circulation to maintain perfusion of vital organs such as your brain and heart. This causes global mesenteric vasoconstriction and reduced intestinal blood flow. Because the problem is low flow rather than a focal occlusion, The ischemia is typically diffuse and patchy. If hypoperfusion is brief, injury begins at the mucosa, but if hypoperfusion is prolonged and severe, it can progress beyond the mucosal layer to involve the entire bowel wall, resulting in full thickness necrosis. Non-occlusive mesenteric ischemia most often affects older, critically ill patients, especially those with cardiac disease or undergoing cardiovascular surgery, and can be worsened by vasoconstrictive agents such as digoxin, alpha-adrenergic agonists, and cocaine. Now let's look at mesenteric venous thrombosis, which accounts for less than 10% of acute mesenteric ischemia cases. Here, a thrombus forms in the superior mesenteric vein, sometimes extending into the portal vein. Because of this, blood can no longer drain properly from the intestines. So what happens next? Blood backs up inside the bowel wall. This causes venous congestion, meaning pressure builds up inside the veins. As the pressure rises, fluid leaks out into the tissue, leading to bowel wall edema. Now, this swollen bowel wall begins to compress the tiny arterioles and capillaries. Even though arterial blood can enter, it cannot effectively perfuse the tissue. Oxygen delivery drops. Since this process develops gradually, symptoms are usually subacute, unlike the sudden severe pain seen in arterial embolism. Mesenteric venous thrombosis is most commonly associated with hypercoagulable states. These may be inherited, such as factor V Leiden, or protein C, or S deficiency, or acquired, including malignancy, hematologic disorders, and oral contraceptive use. Now we continue with chronic mesenteric ischemia. Normally, after a person eats, the intestine becomes metabolically active because digestion and absorption begin. This increases the intestine's oxygen and nutrient demand. To meet this demand, mesenteric blood flow normally increases. This physiologic rise in intestinal blood flow after a meal is called postprandial hyperemia. In chronic mesenteric ischemia, progressive atherosclerotic narrowing of the major mesenteric arteries occurs, most importantly, the superior mesenteric artery and commonly the celiac artery. Because these arteries are narrowed, intestinal blood flow becomes limited. As compensation, collateral circulation develops between mesenteric vessels and their branches, enlarging over time to help maintain perfusion despite reduced arterial flow. However, once multiple vessels become critically narrowed, usually after at least two of the major mesenteric arteries, these collateral pathways can no longer meet intestinal metabolic demand. As a result, postprandial hyperemia fails, intestinal perfusion becomes inadequate, and chronic mesenteric ischemia develops. Patients then develop abdominal pain shortly after eating. The pain is typically dull and crampy and is classically referred to as intestinal angina. And as this pattern repeats with every meal, patients begin to associate eating with pain, they reduce their food intake, develop fear of eating, and progressively lose weight, which are characteristic features of chronic mesenteric ischemia. For ischemic colitis, the focus shifts from the small intestine to the colon, especially the left colon supplied by the inferior mesenteric artery. Ischemic colitis most often results from transient hypoperfusion, a temporary drop in blood flow seen in hypotension, shock, heart failure, severe dehydration, or after major surgery, particularly cardiovascular surgery. Ischemic colitis occurs in approximately 5 to 9% of patients following elective aortic repair, and the incidence is roughly 3 times higher after emergent repair. The colon is vulnerable because of its vascular anatomy, as already discussed in the anatomy section. Quick recap, as this is very important. Watershed areas lie at the junction between arterial territories, where blood supply from one vessel tapers off before the next vessel fully takes over. These watershed areas include the splenic flexure, the Griffiths point, which is between the blood supply of the SMA and IMA, and the rectosigmoid junction, the Sudex point, which is between the IMA and internal iliac arteries. When systemic blood flow decreases, These regions are the first to become ischemic. Clinically, ischemic colitis presents with sudden, crampy, left-sided abdominal pain followed by bloody diarrhea due to mucosal injury. Compared with acute mesenteric ischemia, the pain is usually less severe and patients are often hemodynamically stable at presentation. Now that we've covered the different mechanisms of intestinal ischemia, let's move on to the complications. When intestinal ischemia is severe or prolonged, regardless of the cause, it can lead to the same final complications. This applies to acute mesenteric ischemia, chronic mesenteric ischemia, and ischemic colitis. As blood flow remains inadequate, oxygen delivery drops, and intestinal tissue begins to die. If ischemia continues, this progresses to transmural bowel necrosis, meaning full thickness death of the bowel wall, from the mucosa all the way to the serosa. Once the bowel wall becomes necrotic, it loses its barrier function. Bacteria and toxins from the gut can escape into the bloodstream or abdominal cavity. This can result in bowel perforation, where the intestinal wall ruptures, leading to peritonitis, which is infection and inflammation of the abdominal lining. From there, patients can rapidly develop sepsis. Now let's move into the diagnostic approach. A patient presents with sudden, severe abdominal pain, yet the abdomen is soft with minimal tenderness. This pain out of proportion to the exam is a classic red flag for acute mesenteric ischemia. At this point, we act immediately. We do not wait for laboratory confirmation. The next step is urgent CT angiography. It allows direct visualization of the mesenteric vessels, identifies the underlying mechanism, whether arterial embolism, arterial thrombosis, or non-occlusive mesenteric ischemia, and evaluates the bowel for evidence of ischemia. Once CT angiography confirms mesenteric ischemia, the diagnosis and mechanism are established, and immediate treatment planning follows. Now let's look at a different scenario. Patient presents with recurrent postprandial abdominal pain, described as dull or crampy. It typically begins 15 to 60 minutes after meals and resolves gradually. Physical examination reveals a malnourished patient. This pattern should raise suspicion for chronic mesenteric ischemia. Unlike acute mesenteric ischemia, this is usually not an emergency, but it requires prompt evaluation. CT angiography is the preferred modality here. Duplex ultrasound may be used as a screening tool in stable patient, but is operator dependent and limited by bowel gas. If imaging shows significant stenosis of 2 or more mesenteric vessels, particularly involving the SMA, and the symptoms are consistent, the diagnosis of chronic mesenteric ischemia is established. Last scenario. The patient presents with sudden crampy abdominal pain, most often left-sided, followed shortly by bloody diarrhea. This presentation raises suspicion for ischemic colitis, especially in the setting of a recent history of hypoperfusion, such as hypotension, dehydration, or heart failure. The next diagnostic step is a contrast-enhanced CT scan of the abdomen. CT typically demonstrates segmental colonic ischemia, reflecting injury confined to these vulnerable watershed regions, and also helps exclude complications such as perforation or obstruction. If the patient is clinically stable and perforation has been ruled out, colonoscopy is performed. The colonoscopy confirms the diagnosis by demonstrating segmental ischemic changes. Now let's move to management, starting with acute mesenteric ischemia. Management must begin immediately. The patient is admitted to a monitored setting or ICU, and aggressive IV fluids are started to restore circulating volume and improve mesenteric perfusion. At the same time, broad-spectrum antibiotics are started to prevent bacterial translocation and sepsis. Systemic anticoagulation with heparin is started immediately to prevent further thrombus propagation, and then we get an early surgical consultation. For acute mesenteric ischemia caused by an arterial embolus, the definitive treatment is early laparotomy with embolectomy of the SMA, meaning open surgical exploration with direct removal of the embolus to restore mesenteric blood flow. During surgery, the bowel is also assessed for viability, whether the intestine is still alive and capable of recovery. Non-viable segments are resected to prevent perforation, sepsis, and death. If bowel viability is uncertain, a second look laparotomy is performed 24 to 48 hours later, allowing some ischemic bowel to recover or declare itself non-viable after perfusion is restored. Systemic anticoagulation is continued, and the underlying embolic source, most commonly cardiac, is addressed to reduce the risk of recurrent embolization. For acute mesenteric ischemia from arterial thrombosis, the primary goal is revascularization of the affected mesenteric artery. This is achieved with endovascular therapy, either thrombolysis to dissolve the thrombus or angioplasty with or without stent placement to widen the vessel. If endovascular therapy is not feasible or disease is extensive, open surgical revascularization is required, including endarterectomy, thrombectomy, or bypass surgery. Also here, the bowel is assessed for viability, with resection of non-viable segments, and a second look laparotomy may be performed if viability is uncertain. Systemic anticoagulation, ongoing resuscitation, and broad-spectrum antibiotics are continued to address the systemic effects of ischemia. In non-occlusive mesenteric ischemia, there is no arterial obstruction, so management focuses on reversing the low flow state by correcting the underlying cause, optimizing cardiac output, restoring intravascular volume, and avoiding vasoconstrictive agents. In selected patients, intra-arterial vasodilators such as papaverine or prostaglandins may be used to relieve mesenteric vasospasm and improve blood flow. Surgical intervention is reserved for patients with bowel necrosis or perforation, requiring resection of non-viable bowel. In mesenteric venous thrombosis, ischemia results from impaired venous outflow, so here the treatment is systemic anticoagulation, started promptly to prevent thrombus extension and promote venous recanalization. Supportive care, including intravenous fluids and broad-spectrum antibiotics, addresses hypovolemia and reduces risk of sepsis. Patients should also undergo a hypercoagulable workup, including testing for factor V Leiden or prothrombin gene mutation. Chronic mesenteric ischemia is managed electively rather than as an emergency. The treatment is planned revascularization, most commonly endovascular angioplasty, with or without stent placement, to relieve symptoms and prevent progression to acute mesenteric ischemia. Surgical bypass is reserved for patients in whom endovascular therapy is not feasible or has failed. Ischemic colitis is usually transient and self-limited, so treatment is primarily conservative. Management includes bowel rest, IV fluids, and correction of precipitating factors, such as hypotension or dehydration, to restore the colonic perfusion. Broad-spectrum antibiotics are commonly given to reduce the risk of bacterial translocation. And surgery is reserved for complications including gangrene, perforation, persistent bleeding, or peritonitis.